Hello, my name is Sicco Bus, and I'm an associate professor at the Department of Rehabilitation Medicine at the Amsterdam University Medical Center in the Netherlands. And today my talk will be about the prevention of diabetic foot disease and the role that biomechanics plays in prevention, and then mainly related to the use of individualized footwear. Biomechanics and prevention play an important role in the development in the international guidelines on the diabetic foot, due to the existing evidence on these topics and incorporated in the International Working Group on the Diabetic Foot Prevention and Offloading Guidelines. There are also guidelines on peripheral artery disease and infection guidelines on wound healing and on classification. And there's also 10 accompanying systematic reviews that form the basis of the evidence synthesis for these guidelines. In the prevention guidelines, 5 key elements of prevention are identified. First, identifying the at-risk foot. Then, regularly examining the at-risk foot. Third, educating the patient, the family, and the healthcare provider. And fourth, ensuring routine wearing of appropriate footwear. And that is what we will mainly talk about today. And 5, treating risk factors for ulceration. Now, in most settings, many or all of these elements are combined into an integrated treatment approach that is recommended for ulcer prevention. So let's turn to the biomechanical part of foot ulcer development. In the etiology of a typical foot ulcer in diabetes, motor, sensory, and autonomic neuropathy all play a role in forming callus and local pressure points on the foot that goes unnoticed, which then, under repetitive stress conditions, leads to hemorrhage underneath the callus and eventually to foot ulceration, as you can see depicted here in this diagram. High mechanical stress plays a pivotal role, as is shown by these examples, where the location of the high pressure, shown in pink, corresponds with the location of the foot ulcer in patients who have diabetic neuropathy. The risk of ulceration is particularly high when patients have gone through an episode of ulceration, which is shown in this graph, where on the x-axis you see the number of years after healing of the foot ulcer, and on the y-axis you see the incidence rate from many different studies that we have assessed. And as you can see the trend line, it shows that there's a 40% risk to develop another ulcer within 1 year's time after healing the first one, and 60% in 3 years. So this really stresses the need for prevention, particularly in this high-risk group of patients. Now, for that purpose, custom-made footwear, as you can see, of which you can see different examples here, is often prescribed and has the primary role to redistribute pressures from locations that are at high risk of developing a foot ulcer and where the pressures are high, to other locations in the foot that have lower pressures and are at lower risk of developing a foot ulcer. Many well-designed biomechanical studies over the last 2 decades have shown with which footwear designs we can effectively offload the foot, including the large effect of a rocker outsole configuration that you can see in the middle, giving 29 to 52% pressure relief compared to footwear that does not have such a rocker outsole configuration. And on the left-hand side, you see that the vast majority of cases where this footwear is worn, the pressure can be below a pressure threshold of 200 kilopascal that we often use for ulcer prevention. Also, the use of custom-made inserts that can reduce pressure with 16 to 37%, and also the incorporation of additional features in an insole like a metatarsal pad or a bar, or a medial arch support that has shown in studies to relieve pressure with between 35 and 40%. We just got a paper published on the pressure relieving effect of a full-length carbon reinforcement in the shoe outsole, as you can see in the middle picture, which maximizes bending stiffness and functions to limit the metatarsal phalangeal joint dorsiflexion, and with that, it aims to reduce forefoot pressure. And that is what we found in this study in a group of 24 patients, where at the metatarsal heads, as you see in the table, the pressures with the outsole reinforcement were about 10 to 15% lower compared to wearing this exact same shoe without an outsole reinforcement. Footwear design, we can say, is actually moving from a skills and an experience-based approach to a more data-driven and individualized approach. And pressure measurements has shown to be a very effective way to improve offloading of custom-made footwear, where in-shoe pressure evaluation identifies high pressure points and regions that can be further offloaded by modifying the shoe, as is shown on the left-hand side. And barefoot pressure analysis, shown on the right-hand side, which can identify high-pressure regions to use for automated and computer-driven custom-made insert design and manufacturing. And both these approaches have shown in proof-of-principle studies to lead to a significant reduction in the peak pressures compared to not applying such an approach. More recent studies have shown the beneficial effect of optimizing insole density to the individual subject, with 6 different densities tested, and the most optimal density per subject showed to reduce peak pressure with 45% compared to not having such a footbed. Or, as is shown on the right-hand side, further individualization of insole design using pressure, shape, and also imaging techniques like ultrasound image data in a virtual simulation from finite element modeling techniques that show individualized insoles to reduce pressure with at least 20% compared to the more traditional shape-based insoles. So these 2 studies also show the effect of individualized approaches using pressure analysis. Now, because of the thousands of modifications done in the studies that we have performed over the last 10 years, we were able to create what we call an offloading effect matrix, showing per region of the foot, depicted on the left-hand side in the table, what the effect is of a footwear design element or a combination of elements as shown at the top of the table on in-shoe pressure relief, and is shown in percentage compared to not applying such a design element. The green cells show all the significant reductions, and the red cells show the few significant increases in peak pressure by applying that particular design element for that particular region. So, for example, providing local softening for the metatarsal head 2 and 3 gives a peak pressure reduction of about 16%. Or the combination of design elements such as local softening and replacement of the top cover gives a 26% relief of peak pressure at the 4th and 5th metatarsal head. Now, this can not only help the prescribing team and the shoe technician in defining what to do when measured pressure is high, but also can be used to incorporate in a very initial design of the footwear, where actually in-shoe pressure analysis is not needed. We have accumulated all this knowledge on biomechanical efficacy in a state-of-the-art footwear design algorithm, where based on the type of neuropathic foot that the patient has, which is shown at the top, we define here 14 different domains of neuropathic feet, including the ones with limited joint mobility, claw-toe deformity, Charcot foot, but also amputation, etc. And on the left-hand side, a specific set of design elements that can be used and can be prescribed, related to the shoe, and more at the bottom, related to the insole. The green and the blue cells represent designs for which we have either direct or indirect scientific evidence from studies on diabetic or non-diabetic subjects. And these are mainly for the insole and the rocker outsole, for which we have most evidence. And the yellow elements, for which we have no scientific support and are still based on consensus agreement, mainly regarding the upper of the shoe. Specifically for pressure relief, we have transformed this into a 10-step approach for optimal footwear design, which includes design rules for the shoe and for the insole, as you can see in the second column, based on scientific evidence, and which very accurately dictates what should be in the shoe and in the insole, what type of material should be used, what angles should be used for a rigid outsole, at which percentage of shoe length or locations and geometry for elements placed in the insole. So you see that specified in millimeter accuracy. And it also the specifics of what the top cover of the insole should be. So these are steps 1 to 7. Then in step 8, the more advanced approach is used, where in-shoe pressure analysis is used to evaluate the footwear, and if needed, in step 9, the footwear is modified when the peak pressures show to be above 200 kilopascals. Reassessment of these pressures are then done at 6 months, and if needed, further modification is applied. And this approach, as we have shown in a recent study, works. So in a proof of principle study on 24 high-risk patients, where this design was used in a fully custom-made shoe, which is shoe A, and in a custom-made insole, worn in an extra depth shoe, which is insole A. This approach showed that in more than 90% of the cases, the peak pressure was below 200 kilopascals at the metatarsal heads, where the foot ulcers mostly occur. And these percentages were higher than compared to other pressure-optimized and pressure-driven, data-driven footwear designs. So this approach shows to be effective when it comes to relieving pressure underneath the diabetic foot. And such pressure-driven designs are clinically effective, as demonstrated in the ulcer survival curves of these 2 RCTs. On the left-hand side, the diabetic foot orthopedic shoe trial from our group, showing an almost 50% reduction of the risk of plantar ulcer recurrence under the condition that the footwear is worn. And the careful trial on the right-hand side from the United States that shows a 3.4-fold decrease in hazard ratio from the pressure-driven insoles when compared to the more traditional insoles in plantar foot ulcer recurrence. So what do the international guidelines say about the use of appropriate footwear? The first recommendation is to instruct a person with diabetes who is at moderate risk for foot ulceration, so that's the risk grade 2 from the International Working Group on the Diabetic Foot, or a person who has healed from a non-plantar foot ulcer, to wear therapeutic footwear that accommodates the shape of the feet and that fits properly to reduce plantar pressure and help prevent a foot ulcer. A further recommendation is to consider prescribing orthotic interventions, such as toe silicone or semi-rigid orthotic devices, to help reduce abundant callus, which is a marker for foot ulceration and high pressure, in a person with diabetes who is at risk for foot ulceration, and that can range from International Working Group Diabetic Foot risk grade 1 to 3. For the recommendation for which we have most evidence is for a person with diabetes who has healed from a plantar foot ulcer, where the recommendation is to prescribe therapeutic footwear that has a demonstrated plantar pressure relieving effect during walking to help prevent a recurrent plantar foot ulcer. Furthermore, it is very important to encourage the patient to consistently wear this footwear. Now, this importance of low pressure and the adherence to wearing custom-made footwear, we have made a patient education video so that the patient is also informed about the importance of these aspects. And that is what I would like to show you. Mensen met diabetes kunnen te maken krijgen met complicaties aan de voeten, zoals wonden. Om deze wonden te voorkomen, kunnen op maat gemaakte schoenen worden voorgeschreven. Deze meneer heeft een wond onder zijn voet gehad en krijgt vandaag nieuwe op maat gemaakte schoenen.
Patiënten met diabetes kunnen voetwonden ontwikkelen omdat ze een verminderd gevoel hebben en ook omdat er vaak voetvormveranderingen optreden. Hierdoor ontstaan plekken met toegenomen druk En ongemerkt kunnen zo blaren of overmatige eeltplekken ontstaan. En dit kan weer leiden tot ernstige infecties, waarvoor soms zelfs amputaties nodig zijn. Daarom schrijven we voor patiënten met diabetes vaak deels of geheel op maat gemaakte schoenen voor. De belangrijkste eigenschap van op maat gemaakte schoenen is het goed verdelen van de druk. En daarmee verminder je dus de kans op het ontstaan van wonden. Een goede drukverdeling kun je niet zien of voelen, maar gelukkig kunnen we dat tegenwoordig wel meten. En daarom controleren we alle op maat gemaakte schoenen met een drukmeting die we uitvoeren tijdens het lopen.
De druk is gemeten tijdens het lopen op blote voeten, in de oude schoenen en in de nieuwe op maat gemaakte schoenen. Dit is de drukverdeling tijdens het lopen op blote voeten. De pieken geven de hoogste druk weer. Vooral waar de wond zat is de druk hoog. Dit is de drukverdeling in de oude schoenen. Ook hier is te zien dat de druk nog te hoog is. Hier is de drukverdeling te zien in de schoenen die op maat gemaakt zijn. Er zijn geen hoge pieken meer te zien. Deze schoenen verlagen de druk dus goed, wat de kans op nieuwe wonden verkleint.
De belangrijkste maatregelen in het voorkomen van voetwonden zijn het dagelijks controleren van de voeten op drukplekjes, blaren, overmatige eeltvorming en wonden. Ten tweede, voordat de schoenen worden aangetrokken, controleren of er geen steentjes of andere losse voorwerpen in zitten. En tot slot het dagelijks dragen van de op maat gemaakte schoenen, zowel binnenshuis als buitenshuis.
Samenvattend zijn de drukken in de schoenen zijn goed. En daarom kunt u vanaf nu de schoenen gaan dragen.
Gaan we doen.
Ja.
En als u de maatschoenen altijd draagt, dan wordt het risico op het krijgen van nieuwe voetwonden met de helft verlaagd. Het is daarom erg belangrijk dat u de maatschoenen ook binnen in huis draagt.
Dat gaan we zeker doen. Het was in het begin even wennen, mede omdat die schoenen zwaarder zijn. Nu ben ik er volledig aan gewend. Ik zou ze niet graag willen missen. Ik ben niet meer bang voor de wondjes. En ik kan veel verder lopen.
So, in the design of footwear, we are moving from a traditional, experienced and skills-based approach to a modern, state-of-the-art approach to footwear design, which is based on systematic analysis. So there's a set of design rules that we apply. It's science-based, as I've shown. We have a lot of scientific evidence now to what makes a good shoe that relieves pressure underneath the diabetic foot. It's data-driven, so we can use in-shoe pressure analysis or foot scanning techniques to improve the outcome. And we also know from the clinical studies that it's evidence-based and reduces the risk of plantar foot ulceration. And this represents part of a paradigm shift in foot ulcer prevention, in which we are moving from a stratified healthcare approach, where there's different risk levels for ulceration, and general treatment approaches are applied, and only little customization is applied, to a more personalized medicine approach, in which individual assessments are done and a larger battery of data is collected to determine a personalized treatment plan, with the eventual goal to get the right treatment to the right person at the right time. So with that, I wanted to conclude my lecture and thank you for your attention.